Brave Girl was the second horse we have seen yesterday with the two groups, so in the afternoon. She was this mare who came with the main complaint of being not very nice. I showed the group how to palpate these and get some ideas about the adjustment of these teeth. As a matter of fact, she also had pretty sore TMJs, potentially as a consequence of this uneven teeth story. On the other hand, we also had a pretty sore pole. The mare would not flex sideways properly. She would just give the lower neck a chance to go on the lateral flexion. But the teething, the flexion, and the torquing of the head, which is allowed by the first cervical spine and the occiput towards the atlas, was not very easy to do for her. So we did some tests to see how she would do it, even with a cookie or hay or whatever, and she would not respond so well. So we went ahead to do a full clinical exam anyway. We found that she was a bit sore on her feet. She had a very crooked, narrow-based feet with some various fetlocks. So these were things we decided to address more with the shoeing. So we went back and spent more time about the pole. The pole was abnormal. So we pulled up some X-rays. We actually ended up to do mostly scans on the mare, and when we scanned the pole, we put the scans first. Sorry about that. Okay, so when we put the scans first, I showed the group the way of starting from the parasagittal aspect, so line from the pole. So the pole was like this. We went a bit on the left, we went to the right, we stopped in the middle. We described all the muscles and ligaments, muscles and tendons, nuchal ligaments which attach to the occiput. We always have a tendency to make a kind of a shortcut and say that everything which is painful on the pole is only the nuchal ligament, which is not true. That there are some issues with the nuchal ligament attachment, but there's almost as many on the other structure, which are mostly the semispinalis muscle, the rectus capitis, and the big group of attachment to the side of the occiput, which are responsible of the yes-no function and the tilting. So we went ahead with the scan. You can go through the scans for me. So this is obviously some images that we got in the midline. We cannot see so much on the depth, but from the top down, we have the semispinalis muscle, sorry, oh my gosh, the splenius muscle, scales, splenius, semispinalis. As you go down, normally you should see all the other structure, part of the rectus capitis when you go sideways, and when you go low, you see the nuchal ligaments. You can see it mostly on the longitudinal axis, because when you go off the midline or if you go transverse, the insertion of the fibers are spreading sideways, so you see more an hypoechoic findings. And that's normal. If you actually see something which is echoic, this is not normal, because then your beam is stopped by these structures. And this was the case of this horse. A loss of echogenicity, because these were like calcification of the dots, so we could not see the bottom line of that part, the more ventral aspect of the insertion of the other ligaments, especially the ligaments. And this is a more of the description here on what we can see with this very yeah, okay, so when we go off the midline, we have this image, which is for sure a bit too much light in there, but we can see all the different structures inserting down. And you have to compare this with like when you do a suspensory ligament longitudinal image. So you have the bone shaft, so this is the base of the occiput, and it should be nice and crisp and smooth shaped. And if it's irregular to some extent, you may accept some irregularity because it's not completely flat and smooth when you look at the skeleton, especially on the upper part. But when you go up that slope, it should be kind of smooth and crisp. If it's not, you may have some calcification, spurs, enteropathy. Or in this case, we had a lot of calcification that stops the beam on the side, but we also had almost like a small loop of calcification which was way behind. And this has nothing to do with osteophyte or antesophyte, because this is not on a structure which is actually bonding and inserting on it. So I asked Kurt, and he proposed the fact that it could be kind of a chondroma there, and these can come kind of out of the blue. We cannot always know how much they are clinical, but This one was so big that honestly we could maybe try to block it differentially, like just insertion of that block. I would not trust so much by block because it would kind of diffuse around, but to some extent we would have to think about removing these or trying to inject some product to avoid more proliferation. So the treatment options, unless some other people have ideas, the number one we have is shockwave. That's easy. This is kind of cheap. We tend to release some of this pain in this area. The second one is to try to get PRP and then do some shockwave on the top of that to decrease the pain and also bring some growth factors around the lesions. The third one is obviously surgical removal, which is kind of not easy in this area because it's super deep, and if you go for the surgery, you would have normally to go, or maybe to take off that chondroma structure. And the fourth one, which is kind of a new procedure, would end up to be something we spoke between us earlier on. There's a company in California that makes a probe with a kind of a needle that kind of hand jam the calcification and vacuum it, like aspire this piece of calcification, and you can get rid of these structures. But I'm not sure it's going to work on this huge chondroma that we had behind. So we just show you a picture to remind what we found for those who were not always there. But basically, you have the base of the exhibit, which makes a nice stroke here. Okay, so this would be. Don't forget that you may have some superimposition of the base of the here, the cartilage of the here. This is not. This was the full spur we have seen. There's a bit like a small fragment there, which is kind of like showing an avulsion. But this is not the nuchal ligament. This is way higher. And I would put this maybe in the axis of the spinalis, or off, if it was off the margin of the midline, or like a rectus group insertion area. The shaft is kind of smooth there, so that's the nice part. So that's where the nuchal ligament comes. So that's more the spot I would not refer to a nuchal ligament arthropathy. And here you get to a more caudal part where we had a spur. It's actually here, which was very easy to see also on the scan, and this part there. So these two spots were more, I would say, suspicious of the other calcification going on. And sometimes on X-ray, like you have to look carefully here, because if you super expose this image, you might not see that. You might see that for sure, but then I like again the combination of imaging to see if some structures are going on. Because we were lucky enough to have images of the skull 2 years ago. I just saw them on the phone, but on the phone you could barely see that, and you could see a little bit of a roughening. So in 2 years this horse has gone worse, and obviously clinically as well. So these are the options we can bring up. Okay. Do you have any question on that? No, it was super clear. So intruder, if you remember, was a horse who had a right forehead test. The horse had some other issues, but with the groups I had, I wanted to show you first that this horse was very nice to read because it's a horse who, from scratch, was completely leaning on his left side, So you could see even standing that this horse was protecting his right fore and right hind, if you remember. He had some gluteus atrophy on one side. He had his shoulder completely locked on the left. You would try to pick up the right fore, it was very smooth and easy because it was unloading that leg. You would try to pick up the left fore, it was probably not giving the leg forward. Very sore on this base of the neck, very sore on this trapezoid muscle, latissimus dorsi. So this horse was definitely putting all his weight and shifted his weight to the left side. On the right hind, we also had a lack of motion of his SI and lumbosacral space. He was grumpy when I was squeezing his tubercocci to get a drop on his fetlock on the right hind. His suspensory was sore on the right hind. So we had a very significant amount of information that this horse was not happy to lean on his right knee, forward and backwards. When we dropped the horse, it was a sound right fore significantly, to some degree right hind. We discussed all the options of flexion and everything to go around the horse. It was not so sore when he flexed, but the torquing of his foot on the right fore was not highly significant compared to the left. He was restricted. He was a little bit funny around the pasture joint with a thickened capsule mostly inside. As we went through the day, the morning, this would tend to be a bit shrunk, so it was not easy for the group 3 and 4 to see, but the group 1, I guess, could see pretty well. And the horse was lame, going to the left on his right fore, and would be lamer actually on the soft footing. So it was kind of funky. And so we decided as a group that we were looking at, because the horse was not responding to flexion, having this remodeling of the pastern, history of blocking of the abaxial, history of being lame for more than 5 months. That's okay. We blocked the horse. He was blocked like a couple of days before we came here. So we went ahead to look at all the imaging, and we kind of targeted the problem to be either P1, P2, or P2, P3, looking for collateral ligament tissues, knowing as well that the horse, as he was working and going forward in the ring, would get worse, and we actually show some distension of the joint. And for me, this is something very interesting in a way that if you have a horse that starts the day with a kind of normal palpation and joint looks nice and shrunk and tight, and as he goes and you stop your exam and you give some time off and you go back to the horse, you get some extra pulse, you get some distension of the joint. These are the horses that I care about potential joint stability. So again, I was more inclined to see something and give relevance to something affecting the joint itself, stability of the joint, collateral ligament issues, maybe bone issues around, but the horse dramatically worse on the soft footing. On the bone scan, the horse showed up, especially when you look at the front limbs like this from the side, that he had more uptake on P2 in conjunction with P3. We got these images reviewed by Kurt, which on the MRI is way more interesting if you can go on the MRI. I would not be too arrogant with the MRI, and maybe Kurt can discuss that, because otherwise you won't come to much this morning. Could you comment on the MRI for us? Sure. And then we can come to the kind of a conclusion, because this MRI is interesting in a way that if I have Kurt out of the blue, if I imagine Kurt not being a clinician, which is so I'm happy for that, you would have so many information on this MRI that you can get lost. So this is a very, very nice example for me to then make a triage of all the information you get from the clinical and give less or more significance to some of the lesion that is going to show up right now.
So there's a couple of things. So I use T1 GRE, which is this, and then a sturge, which suppresses all of this signal here, which is fat. And this helps you see increased signal within the medullary cavity. If we look between these two, this is an immediate signal on the T1 image, and this matches up here. This is not sclerosis. This is not necessarily sclerosis. This is what we would call either fluid or water signal, whatever you prefer, and you can see that same thing sitting right here. This horse has widespread increased signal on the fat suppressed images, indicative of a couple of things, either transient edema, contusion, hemorrhage, could be abnormal trabeculation, fibrous tissue, or osteonecrosis. And when I look at these particular images, this signal, I compare it to the joint fluid. As these start to get closer, that means that we're moving more towards what joint fluid particularly is. And when that happens, that's a severity thing to me. And I would say that as I'm looking at that, I would really think about osteonecrosis as it's moving towards osteonecrosis in this particular case. So this is very, very bright comparatively to very similar. And sometimes these horses, as you recheck them, they either get much worse, they start to completely degenerate their navicular bones, or they start to get better. And I'm not sure the breaking point of that, but that is what I see here in this particular case. And it's widespread. It's in proximal P1, distal, or proximal P2, distal P2, all on the P3, and then the navicular bone. I think that realistically, those are probably the biggest things that I saw in this case, is the widespread amount of increased signal on the fat suppressed images. As we look at some of the soft tissues, just to run through this, right? I look at the deep patellar flexor tendon. I don't see any real big lesions in the deep patellar flexor tendon. A lot of people overread this area. That's a common area for artifacts, so don't do that. And as we come up more proximally, right, we want to look at the collateral ligaments here and here. Those look relatively okay on this MRI. And we come down to the distal interphalangeal joint here and here. Those are the collateral ligaments of the distal interphalangeal joint. Those are relatively okay as well. So the good news about this one also is that we have bilateral, so left fore and right fore, and sometimes that helps you further evaluate certain structures that if you only have one side, it can be a bit of a challenge. If we look closely between these two particular studies, here and here, now we look at the distal interphalangeal joint. You guys see the difference between these two particular studies? This is very, very wide, and you can see the cartilage between the two. Here we start to lose some of that cartilage. That is helpful because if we look at these, this is narrowed. Now, do we have other imaging that can potentially help us convince ourselves that there's narrowing besides this particular study? Is the radiographs here? So if we look at the radiographs as well, this is a really nice example of what I talked about earlier when I was getting my photo taken. Is that when we look at these two studies on this 60-degree DP, now we see the difference between the left fore and the right fore. There's narrowing along that dorsal aspect. This image, again, I like this image a lot to look and convince myself of narrowing the distal interphalangeal joint in that particular area. The non-weight bearing, I think, is sometimes helpful because that leaves the limb not compressed one side or another. So this horse is now on two different imaging modalities, has narrowing of the joint and diffuse cartilage loss. The diffuse cartilage loss can be a bit challenging. So it has, I would say, osteoarthritis of the distal interphalangeal joint, in addition to one of the things that transient edema, contusion, or osteonecrosis in the foot. This, I think, is going to be quite difficult to manage. So when we look at this, the challenge is it's a little bit thicker on this side, a little bit thicker on this side than this side. The challenge is this particular sequence does not show my soft tissues very well, so I'm not comfortable calling any sort of abnormality in this particular region because the gradient echoes are the worst thing to look at for some of our soft tissue structures because they lack that contrast. So realistically, what I want is a fast spin echo to look at that particular area, and you can see we're losing some of our superior. So I don't have any good sequences on this MRI to tell me yes or no versus that this is an abnormality. There's a T1 right here that we start to see the collateral ligaments here and here. That's what I see the normal on this particular sequence. It's one view to look at on this right fore. So I'm not convinced of much of anything. So if I have clinical suspicion, I might go back and ultrasound it or I move the coil up.
So we ultrasound this horse and the collateral ligament on the medial aspect was definitely thickened compared to the lateral aspect. Maybe not to a degree that it will be, but I will keep it in my pocket with the coffin joints narrowing as a follow-up treatment. But as Kurt mentioned, I'm not sure the management is going to be easy on that one, on the long run. It has also a very odd foot shape. So these are typically the ones I want to do the best treat I can first, and then see what are my treatment options to follow. Because if it's so worse on the soft tissue, and I don't explain completely why this was so lame on the soft footing compared to the hard when you see so much more edema and joint narrowing. The way they would be worse on the hard footing of the circle with the torquing. So this is one part that I was thinking to maybe block just P1, P2 first, and then you come back and block the coffin joint. Even though we know that there is a lot of potential diffusion and you don't have kind of a straight answer.